Today we have administered radioembolization to an 80-year-old patient. A year ago, the echo scan was effected following his complaints of discomfort in the lower right abdomen. This scan revealed the tumor of the left lobe of the liver. A follow-up CT conducted at our medical center showed a very large, over 10 cm, externally propagated tumoral mass in the left lobe of the liver. Morphological examination of a bioptic sample revealed a hepatocellular carcinoma, that is, a primary liver cancer, one of the most common primary cancers. Additional tests showed that the tumor markers of alpha-theta proteins were only slightly over the normal parameters. A subsequent thorax and abdominal CT with contrast medium revealed no distant metastasis. We have discussed the patient at medical consultation and, considering his age, active vascularization and the size of the tumor, decided to consider the patient for radioembolization of the liver. We already are at the main stage of the treatment, that is, radioembolization of the liver. Several weeks ago, we had completed the stage 1 and stage 2 by injecting the Macrotech medicinal product. During the first stage, we identified an afferent vessel, which is the left hepatic artery. All our procedures can be clearly seen directly on the screen. We see a big blood vessel. The blood supplied to the liver is Mitchell's 1 type, so it has classical anatomy, rather comfortable for the surgeon. Our goal today is to reach the artery and to prepare the box, we'll show it in a minute, and to inject the microspheres into the tumor. The introducer is now in the artery, we have the access to it. The next goal is artery catheterization. Our previous experience with this kind of operations allows us to know with certainty which catheter to use. It should be mentioned that the first stage of the surgery is very important during radioembolization, because during that stage we understand the vascular anatomy of the patient, with different options of blood supply to the liver. Also, we find afferent arteries that feed the tumor. Good quality devices allow us to make a flat detector CT, and we'll show it soon as well. We set 2 positions for the device, lateral and frontal. Find the left lobe of the liver and make it visible on the screen. Hold your breath for a few seconds, please. You can breathe now. Here on the screen we can clearly see the CT picture with a big tumor. My colleague further will make a delineation from the workstation next to the operating room, and the device will show us the branches irrigating the tumor. During the first stage we also did this, but we think it's important to make it at all the stages of the surgery, because neoangiogenesis isn't predictable and we can often see the formations of new vessels in the tumor. I'm almost certain that it would not affect our today's tactics, and for the most of the time we don't need an anesthetist, and especially general anesthesia. Unlike chemoembolization, radioembolization has much fewer harmful side effects and often has no consequences at all. Here we can see the base image and the overlay image. The picture on the left shows us where we are right now, and on the right is where we've injected technetium, and as you can see, the positioning is exactly the same. You see the bifurcation on the left and on the right. The box itself looks quite tidy. The system of Microspheres injection consists of a reusable protective box and a kit of lines, tabs and disposable needles. The box casing is made of transparent acrylic that blocks the radio emission of Etrim-90. There are no other radio emission sources in the Microspheres. The disposable system parts kit and ampules with Microspheres come in different packages. All elements of the kit are sterile. The ampule with Microspheres is delivered to the hospital on the day of surgery. The assembly of the kit requires following the aseptic rules. An assistant can follow a simple and detailed instruction to assemble the kit. All the manipulations are carried out with a 20-cube syringe. The total volume of fluid administered to the patient is no more than 60 milliliters. After assembling, you need to expel all air from the system pipes. Then an assistant unpacks the shipping container with Microspheres and puts the ampule into a special holder of the box. We monitor all the manipulations with a dosimeter. You need to be careful with those, but really, no worries. We put 2 needles to the ampule with Microspheres with Etrim-90. One needle to get rid of extra air and the other one for the injection itself. Right now we need to expel the air out of the entire system. And very importantly, we must do it really slowly and precisely, because if we push too hard and fast, the Microspheres will spread all over the system, so that instead of the air, we would risk to remove Microspheres. That is why we work very slowly and can see the saline coming up, but not the Microspheres as we control the speed. Okay, now release it. We can see the needles going down into the ampoule with microspheres, and now we begin to inject the microspheres. I've already injected 20 cubic milliliters, and the amount of microspheres inside the ampoule should be very low now. We usually cover the top of the box with the lid, but now for the purpose of showing it to you, we don't. How do you feel, Anatoly? Does it hurt? No pain at all. That's exactly what I was talking about. During chemoembolization, most of the patients are feeling discomfort, but with radioembolization, it's not happening. I think we're done, and now I can disconnect the system. Now we need to check everything with contrast. Hold your breath, please. No effects of embolization. That's the first good sign, and the catheter is in place correctly. It means that we've reached our goal for today, and now we need to make a hemostasis and single photon emission computed tomography SPECT. Thank you, everyone. Today it's time for Etrim therapy, which is radioembolization with microspheres with Yttrium-90. Before that, we've tested it out with technetium and microspheres with albumin, and we got the results and established an individual dose. Today we have an examination after the injection of Yttrium-90, and we've got an image with gamma camera to double-check the correct placement of the microspheres. And then we'll continue watching the treatment process. The first stage was diagnostic. The second is the treatment stage. Right now, the effect CT, single photon emission computed tomography, is in process. We do the total body scan to make sure that all the parts of the body potentially receptive of the tumor are not affected. We did the same with technetium. It's important that the particles do not settle in the stomach or the lungs, although the minimal doses are permissible. After single photon emission computed tomography SPECT, we analyze the results, and in 15 minutes we'll see those. The device is a tomographical gamma camera combined with CT, and the CT is used to control the absorption correction, but it's not necessary for Yttrium-90 because we use Bremsstrahlung and later can show the difference in the picture with and without the absorption correction. In this case, we need to verify the localization of the tumor. The first stage with angiography we did 2 weeks ago. I've talked about it before. Here is an image with clearly showing the big and ugly tumor right here, at the left lobe of the liver. Meanwhile, the right lobe is intact. No tumors here. After angiography, we found an afferent and feeding vessels of the tumor, basically the left hepatic artery, which was covering the tumor with its vascular branches, and we've injected Macrotech to this vessel. After control single photon emission computed tomography SPECT, we understood that the medical product is localized within the tumor. There is no extra organic propagation, and in-lung dispersion is only a few %. That allowed us to count the volume needed and exact activity of Yttrium-90. Then asked BEBIG company for the product, and they've provided us with the kit on the date we need it. The angiography shows that we have almost no changes in those 2 weeks, so today we've made the same operation as 2 weeks ago, and we are expecting good results. After all, if a surgeon gets identical results of single photo emission computed tomography SPECT during the injection of technetium and Yttrium-90, we can define the intervention to be successful. Since we use the femoral approach, the patient has a strict bed rest, control of analysis, biochemical blood test, and complete blood count to watch the platelets, transaminases, and alkaline phosphatase. They may be a little over the normal values, but not over allowable fluctuation rates. And after that, we can say that the patient is ready for discharge. Most likely, we'll discharge him tomorrow. After that, in 1 month, we repeat the CT scan to make sure that everything is alright and we get no symptoms throughout this month. The next CT is after 3 months past the radioembolization. The first CT is done to exclude the complications of the disease and tumor abscess formation. We know that during the first month, the decay of yttrium is particularly active and can lead to tissue necrosis, any possible sign of which should be identified as soon as possible. We wouldn't expect huge results in 1 month, because in fact the tumor is still in process of edema and it's normal in 1 month. However, if we see the growth in 3 months after, that's a bad sign. We had a surgery on 25th of April 2019, the tumor was the same size as this one, but in the right lobe, and the prognosis of the patient was extremely poor. Unfortunately, he had virtually no chances. But today is the 25th of June 2021, and he is still working, enjoys his hobbies, his friends, and his granddaughters. In sum, the life goes on. He had 2 of radioembolization treatments so far, and to this day we see positive results. We cannot see the clean image, we can only see the Bremsstrahlung, so the image is approximate. We can immediately see that the product is inside the tumor exactly as we want it. In fact, we got the same spreading pattern of either technetium or yttrium, which is considered to be a successful radioembolization. And we're happy, especially for the patient. We'll continue monitoring the tumor and its reaction to yttrium.